Okay, should have you covered.
Okay, next. Okay, so the green area in here is what we're going to talk about today: hybrid effectiveness, implementation trials, mixed methods, designs, and testing for implementation strategies using quantitative methods. Next. Here are the competencies that we've specified today. We're going to identify some characteristics of important useful implementation designs, why equity is a critically important issue in implementation, what kinds of questions are asked and answerable by implementation research designs, the advantages of using what we call randomized rollout designs. They include stepped wedge designs, which we'll talk about, and also mixed methods. Next. The agenda is that we're going to talk about characteristics of these implementation designs, start with the quantitative side, go to mixed methods. Wouter is going to give an example in here. We're going to go off to the discussion groups. Next. These are the readings. Everybody has a copy of those. Next. So here's the things about a good design. Where it starts is to have an ethical and just design that has the support of the community, the organizations, key stakeholders. When you run a randomized trial in an efficacy or effectiveness mode, we talk about equipoise. Equipoise is an important concept. And here, I'll talk a bit about that later on, because in implementation science, even what it means for equipoise is quite different. So I'll come back to that as a point later on. Good design has the capacity to answer multiple questions cleanly that stakeholders care about. It's practical. It doesn't interrupt services, so you can't take and overwhelm people by measurements, and it produces value. Otherwise, why do it? Next. This is the traditional translational pipeline that runs from efficacy trials and effectiveness trials to implementation research and practice at the top of the scale in here. The point about this is that as we talk about what data are available in here, we find that, as we go to the next slide, the inequities that happen are structurally worse at the end of the pipeline in implementation, even than when they are combined together in the efficacy and effectiveness. So that's from two main reasons here. Evidence-based interventions are generally established with efficacy and effectiveness trials that are conducted mostly on majority populations. So even at the beginning in here, we don't have a really good range of populations to start off with. A few implementation studies actually do look at issues of including disparity populations to a sufficient degree, and we'll give you an example of that. And the current NIH priorities are stacked against it because they require proven effectiveness at the population level of risk before you go through an implementation study. Next. So the basic issue is implementation research is a failure if it doesn't address and fix health disparities. That's the point of this one. If we don't address issues on moving the scale so that the disparities are reduced in here at the implementation phase, we don't really understand what's going to happen, and we're going to be actually making things worse from anybody, sort of a reverse Robin Hood kind of effect. Next. There are some critical differences between implementation and efficacy and effectiveness studies. There are some similarities as well, but I'm going to emphasize the differences in here. What gets evaluated in the efficacy and effectiveness world, it's the thing that we talked about. In implementation, it's the how to deliver the thing. In terms of validity, efficacy and effectiveness trials focus on internal validity, whereas implementation talks about external validity. What are the contexts about which it works or not? There's more control in an efficacy and effectiveness world than there is in implementation. That's by design, and designs have to be taking care of that. When you assign to conditions, you can randomize in efficacy and effectiveness trials often at individual level, but you can also do that at group level, you can say clinic level, for example. In implementation, it's almost always evaluated with randomizations at, if there's a randomized trial, at the service delivery system, that is counties, clinics, etc. The outcomes that are measured in an efficacy and effectiveness world are individual health outcomes. That's the primary outcomes. Whereas in implementation, the focus in here is on system level outcomes, including reach, can include leadership kind of roles, etc., that we've had before in terms of Enola Proctor's measures of outcomes or the re-aim outcomes, for example. And then this last point about equipoise. People know that it's improper to run a randomized trial in an effectiveness study in here if we really believe that one intervention is much better than another one, and we don't have any real questions about that. So it's unethical to do that. In implementation studies, the real question is with, we're starting with an intervention that we know works. Otherwise, why would we do an implementation study? So we talk about rollout designs where all the systems eventually get the implementation strategy that we think is going to be successful and get therefore the evidence-based intervention. And we'll talk a little bit about that later on. Next. So we're talking about a range of different kinds of studies that are done. These are trials, randomized trials that include at one level clinical and effectiveness research. At the other extreme is implementation research. And inside that, there are hybrid designs. 3 types of hybrid designs are available in here. Hybrid type 1 is primarily a clinical intervention study, which is powered for that to work. But it does collect information on how well implementation is working in those particular contexts. Hybrid type 3 is just the opposite, where it's primarily an implementation trial, but you can collect information about, does the clinical intervention still work in delivering outcomes that matter to the individual level and their health. And hybrid type 2 is a combination of those two, so that you can measure both the effectiveness of the evidence-based intervention was originally there, as well as test the implementation strategy. Next. There are multiple different places where you can do implementation designs. We've organized this by stages in EPIS that you have had before. In the exploratory phase in here, many of the reasons for doing implementation designs is to study decision-making, what, where, and when to implement. In a non-randomized study, you can use agent-based models and other systemic interventions and implementation strategies. Voucher is going to be talking about the use of agent-based models in a few moments. Preparatory phase, there's really not very much in the way of designs that I know about. It's just, does it happen or not? Maybe there's more reason for doing more of those. In implementation with fidelity and sustainment, though, you can do non-randomized studies. We talked about pre-post designs where you measure the beginning and then before it's delivered, and then post designs when an implementation study has gone on, as well as quality control studies that we've had earlier in a number of presentations. In randomized studies, and here we can talk about rollout designs. Next. So there are 3 common questions asked that are addressable by implementation designs. First of all, is a new implementation better than the existing one? Here we can use stepped wedge designs. Many of you have heard of those before. And their broader class, which we call rollout designs. The second is comparison of 2 implementation strategies against one another. Which one looks better in terms of implementing an evidence-based intervention? These are called head-to-head implementation trials. A third one in here, does implementation improve over time? A quality improvement design would be useful here, as well as what people are calling a criterion-based design, which is essentially similar. Next. So let's go to rollout designs, including the stepped wedge. So there are 3 things that we're going to talk about today. One is that all of these have the following characteristic. They have both within and between site comparisons. I'll talk about what that means by showing some diagrams in here. The examples will be for rollout, different kinds of rollout designs, including step wedge design, but other ones as well. And then look at what are the advantages from the perspective of the community as well as the researcher. Next. So one type of rollout design is a stepped wedge. So stepped wedge designs are classically the following. They have only one new implementation strategy they're looking at. They randomly assign when units receive the new implementation strategy, and all of the units have a crossover into the new strategy. And then finally in there, they can be used for implementation or hybrid designs. Next. So this is what a step wedge design looks like. The blue is implementation as usual, what's around at the beginning. And the green is the new implementation strategy. Here we have 11 steps conducted at 11 different time points. The vertical line in here says that each time point, we have ability to compare a set of units, that is clinics or other conditions in here, that some of them are in the implementation as usual condition and the others at the new implementation condition. And then if you look at the next line, the horizontal line says that every single one of these units has some time that they spend in implementation as usual, and then some time as in the new implementation. So that's a within comparison in here. So between and within comparisons are done at the same time, which is really its strength. Next. So what does a step wedge look like? Abstractly, it has steps. So you can see in this last diagram, we had steps in here. This is 11 steps. Next. And it has two wedges. These are complete wedges. One is the lower triangular control wedge, and then an upper triangular intervention wedge. Next. So this is a Escher diagram in here pointing out there are lots of different steps that can be done, including ones beyond the stepped wedge. So here's the next one. Next. This is a trial that we're running in here. And note that there are 3 implementation strategies. One is the initial control strategy. The second one is eHealth Familias Unidas intervention that is being implemented. And then the yellow in here corresponds to the same intervention when you're letting the implementation be delivered with less strength in terms of the research support in it in a sustainment period. So it's got 3 different ones associated with the kinds of transitions that are here. Next. And this is a randomized rollout design that's going on right now in Chicago, in Northwestern, dealing with 2 intervention conditions. It's a new one. The implementation is a new implementation strategy to address depression in public and private and clinics in the Northwestern system. And then there is a sustainment period that's followed in here. But you notice that there isn't any measures, formal measures, at the beginning of the study in the lower triangular area. So that's a difference in here. It's not the exact same rollout design as we had with the stepped wedge. Next. So rollout designs tend to be acceptable to communities and organizations. People we've talked to like the idea of rollout better than stepped wedge anyway. It's a much less difficult term to try and deal with. But communities really generally like it because there's no pure control. There's no conditions that never get the new implementation strategy that you think is going to be useful, and therefore you don't get the potential benefits in it. Randomization and the ordering is fair. There's value to going first. That is, that you think it's going to work in here, and so people are very often eager to get it. But then if you go later, there may be improved implementation as you learn more about it, and so you can gain more about having a better delivery of that program. From a research standpoint, it's a true randomized experiment. The randomization is at time rather than site. And then the second one in here is that it has strong power generally because it has both between and within site analysis. Next. This is an example of a parallel group design, which is an alternative kind of design that people use, where all of the sites start at the same time. You can do implementation strategies of the blue versus the red at the first time point in here and evaluate it. But you can see that you're only getting half the data that you have in a rollout design, where you have a lot more that every individual site has both conditions in here. So typically you get more power basically on that. Next. We're switching now to looking at head-to-head randomized implementation trials. You can do these as rollout trials as well. Here in the left-hand side is implementation strategy 1 for a specific evidence-based intervention. Next. And then there's a second implementation strategy that you're going to test head-to-head with this one, but it has the same evidence-based intervention you're using. Next. And what you're doing is randomizing service systems to get either implementation strategy 1 or 2, next, and measuring those on the implementation outcomes. That's the primary set of outcomes that you have. Next. Finally, the third way of looking at implementation trials, and here is to test to see whether improvement occurs. So as you roll out different sites and getting an intervention in here to do an implementation strategy, you might want to test to see whether you're improving over time. So the bottom line is here is what a statistical power analysis suggested that the first clusters, the initial clusters, would get to achieve 30% reach into a defined outcome of what they were delivering, versus one where the later clusters would get to there in 5 months rather than 25 months. Next. Okay, so we're going to switch to mixed methods right now. A couple examples with Larry Palenkas to do this one. Qualitative methods are inductive, whereas quantitative methods are deductive. Mixed methods combine the two. Next. So I'm going to give you 3 examples of how to combine the data together to get mixed methods. When you look at merging the data, collect the data qualitatively on one side, another studies as quantitative data, and you combine the results of those. You can also connect the data. So you can do qualitative data first, and then follow that with quantitative data, which is informed by that, and get the results. And the third one is embedding the data, taking quantitative data, for example, and building in a component of qualitative data and getting results. So these are 3 illustrations. The first one in here corresponds to merging the data. These are examples of looking at sustainment, which is the least tested and evaluated part of implementation. How can states sustain programs to reduce the opioid deaths from the federal dollars that are given? The first step in here was looking at qualitative interviews of 16 state leaders in here that got published as evaluations associated with the qualitative data. And then there was an additional separate paper that looked at quantitative evaluations of sustainment by taking information from the applications that the 50 states had, and evaluating them in terms of their level of sustainment, and then looking at integrating administrative records on the population need and services that Carlos Gallo led. The second example in here is to connect the data. You can talk about sustainment of state and community prevention programs funded by SAMHSA. Larry Palenkas first did qualitative interviews of sustainability, and then followed that up with a survey that was created to predict sustainment. And then finally, this last one in here is looking at influence networks within an implementation trial. So you can look at a implementation trial, which is typically quantitative, and then embed it in terms of a combined network survey of who these influencers are, that based on qualitative interviews as well as quantitative interviews. So next, we're going to summarize this part of it before we go to vouchers. Equity is essential for implementation designs. Implementation trials answer three things. Can a new implementation be better than implementation as usual? Can you compare two implementation strategies with a head-to-head design? And is implementation improving over time? Rollout designs can be fair and have a good statistical power, and they're often used in these studies. And the mixed methods are nearly essential for any implementation study that I've been involved in. So I'm going to turn this over to Wouter now.
Thank you, Hendrix. So Hendrix asked me to talk a little bit about some of our new methods of exploring different strategies and targets using agent-based modeling. So just to give you a little bit of a context, I'm going to be talking about an agent-based modeling project that was built to support a local health department in Chicago to optimize their care portfolio specifically related to HIV. The question they had was, given that we're living in this world where we're trying to end the HIV epidemic, what are the best care and prevention pathways towards achieving that aim? And just to give you a little bit more context, I think the HIV epidemic is essentially an effort to reduce the new number of incidences annually by 90% by 2030. And this is primarily done through some novel interventions developed specifically relating to prevention and treatment of HIV. So what we did to support this project was we built an agent-based model. An agent-based model is a simulation model in which behaviors of individuals are represented in a computer simulation model. This specific model here focuses on the men who have sex with men in Chicago, as that's the predominant population in which new incidence cases of HIV occur. We scale it down because otherwise our model becomes too computationally heavy. And this model specifically was based on 2015 data and is aimed to project a 15-year period out from that data onwards. We validate this model using some available data in terms of the epidemic that is available through our partnership with the local health department to ensure that our model is actually capturing dynamics that are realistic. So we're matching the real world there. In a nutshell, this model consists of 6 different modules, and I'm going to sort of talk about what the function is of each of these models, just to give you a sense of what's in such a model. I won't go into the details because I think that's if you actually want to read those, I suggest the additional reading this week actually has a reference to this model, and that reference holds supplementary information that describes in 50 pages how this actual model works, but details are not necessary to sort of understand what we're getting out of this modeling effort. So first, we make sure that we're capturing demographics that are representative for Chicago. So we want to build a model that really acts and behaves like the Chicago setting. We put in that model different kinds of partnerships because we're talking about HIV transmission. We're really talking about the sexual connections that are occurring within this population. So we base these on local data about sexual partnerships, and we have in our model these what we call agents, which are essentially individuals, interact among one another. And through that interaction, there is spread of HIV, and through the influence of a care system, both in terms of treatment and prevention, there is an impact of the health department onto this system and onto the spreading of HIV. We specifically have a module that covers some of the local determinants And that's really there to ensure that some of these drivers or the effects of disparities are captured in our model as well. In our first efforts, we tried to build something without these determinants, and we found that our model was behaving vastly different than the real world. So that's to show that simple risk factors alone are not sufficient to understand the actual dynamics that we're seeing in a city like Chicago. And then the last module is an intervention module, where essentially we as researchers look at certain things we can do as a health department and see if we do X, what is the impact of that on a system level over time. So specifically about this intervention module, we identify 6 levers of change, and we're specifically talking about levers of change because these are specified at a higher level than an implementation strategy would normally be. So it doesn't tell you how to do something, but it tells you what to target. We specifically identify 6 different targets, 3 for prevention and 3 for treatment. They essentially cover linkage to either prevention or treatment, adherence to such a regime, and how people are retained over time throughout such a regime. And for each of these levers, we have different levels or different strengths of dose. So we're varying the extent to which each of these levers is changed in our simulation. And then with these different interventions, we're exploring what combinations of interventions actually yield the result that we desire. That 90% reduction of incidence by 2030. So what you get is something like this, and I'll talk you through this in more detail. So on the right-hand side, we have this set of levers that are active, and on the left-hand side, we have a tree of potential pathways of intervention with their represented effectiveness. So for example, this top element represents which percentage of the individual intervention scenarios, so combinations of interventions, will be effective in the goal, and in this case, the goal is 75% reduction by 2023. This is the complete set of, the top is the complete set of interaction. Then we have a branching out in 2 trees, one describing PrEP linkage, so essentially lifting PrEP linkage to at least the level 3 or higher. And what is the improved chance of attaining that goal of 75% reduction by 2023? In this case, we jump from 21, which is the top note, to 35% just by adding that set of interventions. We can further branch it out by adding another requirement on the set of interventions so that we're further improving our chances of getting towards our goal of 75% reduction. And then in the end, we see this combination. So the section of green interventions in the table on the right as a requirement for attaining a reasonable chance to getting towards our goal of 75% reduction. So this shows us that to get to 75% reduction by 2023, we need an intervention level of at least level 3 for PrEP linkage, at least level 2 for adherence to PrEP, and at least level 2 for retention in PrEP. And what these levels mean, I will not go into the detail, but it gives you a sense of what severity of interventions are needed on a systemic level to get towards your goal. So this was the tree for an intermittent level, but we also did it for the 90% reduction level by 2030. And you'll get a similar picture. A few things to note here. Not only do we see that only 6% of all the scenarios that we modeled actually do get to achieve that 90% reduction goal, which is extremely low. We also see that we need severe interventions to up that probability only slightly. So even in the severest scenario, we only get 58% likelihood of actually attaining our goal of 90% reduction by 2030. just to give you a sense of what this modeling also does in the background, essentially what it does is it looks at incidents over time, given a certain set of intervention scenarios. So if we take, for example, the real observed values that we have data on after we designed our model, so the period of 2016 to 2019, and we use our model to align that with what we actually observed in that period, we can get a projection of where we're currently trending, which is what is depicted here over time. With these horizontal lines, we put the targets that I just talked about, the 75% reduction or the 90% reduction targets for 2023 or 2030, respectively. And what you can see is that our model allows us to make an assessment of how likely we are currently to get towards those target levels of new incidence cases, simply based on the modeling projections we have. And unfortunately, in this case, it seems very unlikely that with the current trend, we would be able to attain these targets. So how is this information relevant for decision makers and during exploration? It does not necessarily provide you an answer or a roadmap of what should I be doing next, but it does present you with information on where to target your interventions. So it really is a conversation starter in many cases. So what we can do is, by mapping these different levels for each of the levers, we can quantify what would be needed in order to get to this target. Rather than just setting a goal, we can actually quantify the required change that needs to occur to get to that goal, which can then be used in conversations with the health department to specify where they should be putting their effort, what they should be focusing on. Similarly, when you have these kind of models and you are in the implementation stages and getting some of the gains that you're making, you can use these models to evaluate whether the changes that you're making are sufficient to get towards the goal in this case, or where they are likely to get you over time. So it's another way of benchmarking your current progress. And similarly, you can do projections based on these models that will provide evidence rather than hypothetical impact for your intervention programs. Just as a little bit of an extra tweak to this is all work we have done. What we are doing right now is taking a step away from these levers of interventions and actually considering different implementation strategies and seeing the specific impact on those on a system level. So that will require modeling that's a little bit more detailed than this model that I'm presenting here. But that's the direction that we're moving in. So moving beyond the simple phase of exploration and going a little bit further than that, using this similar modeling methodology. And on that note, I will give it back to, I guess, Sarah for some final thoughts before we head into discussion.
Wonderful. Thank you. And thank you all for bearing with us when we had the slight delay at the beginning with our technical difficulties. We're going to break into our breakout rooms now. I saw there was one question in the chat, but it looks like it was answered. But actually, there were a couple questions in the chat. So if you haven't noted the chat, when we upload the slides, we can try to capture the questions and answers here too, and put those up with the slides as a resource in case people weren't able to note those. All right, so we'll go into our breakout rooms and continue this discussion and elaborate on our learnings about new designs.